you, Hassan, and thank you, John, for organizing the event, and Dr. Hassan for collecting more than 100 skull-based surgeons from all over the world to participate in this meeting. The my topics today is on deciding the approach for suprasellar meningioma, depending on the site of attachment of the tumor. Uh, Suprasellar meningiomas, they can have attachment to different parts, like they can have attachment to the tuberculum, they can have attachment to plenum or the plana or diaphragm sellae, and they can be attached in the midline or paramedian just medial to the optic canal. Normally, we operate on the side of visual loss. If a patient has come with, like this patient who comes with a visual loss on the left side, normally we treat from with the left diurnal craniotomy so that we can see the optic nerve and decompress do an optic canal decompression and then remove the tumor. We were following the same thing, operating from the side of visual loss. And then we had published earlier in 2002 and as well in 2012, our results of suprasellar meningiomas by operating through the ipsilateral from the side of visual loss. Now, when you compare that time, the visual improvement and visual worsening, if one can see that we had almost 7% of our patient had visual worsening after surgery, and if similar results are operated by other authors ranging from 9%, from 0% to 20%. So this was an unacceptable high risk of visual loss following surgery. So the existing literature said that the post-visual deterioration was almost the tune of 20%, and gross total resection was around 70 to 90%. But with the advent of endoscopy, when people started to do through the transnasal route, doing with an endoscope, the results were the results were better, especially because the optic nerve was not manipulated and the tumor was removed medial to the optic nerve. So these patients had a lesser chance of visual deterioration and a higher chance of visual recovery. But doing endoscopy, it cannot be done in all the cases because more than 3 centimeter tumor, it cannot be done. Or if the tumor has encased the vessels, it cannot be done. If you have a calcified tumor, it cannot be done. And the chances of CSF leak also was higher. And many times you have satellite nodules, which ranges from 2 to 4 centimeter from the margin of tumor, and they are the cause of recurrence, which cannot be dealt with an endoscope. And at least 2 to 5% of the cases can have associated aneurysm of the paraclinoid ICA, and this cannot be treated with endoscopy. So we prefer to follow doing a transcranial approach, but we wanted to use the advantage of the endoscopic principle in transcranial surgery. So here, we changed our approach, operating the tumor from the opposite side. So if you have a left side visual loss, we operated from the right side so that we remove the tumor without manipulating the optic nerve like what we do in transnasal endoscopy. And we hypothesize that if we do this way, then the visual recovery will be better because we will not manipulate the optic nerve. As we know, the intracellular tumors, the attachment can be midline or it can be paramedian, either to the right side or the left side. And the visual loss depends on which side it is attached. If it's midline, there is bilateral visual loss at the same time. If it's paramedian, usually the visual loss is to the side of attachment. Following this principle, from 2016 onwards, we identified tumors which had midline attachment and which had paramedian attachment. Depending on that, we followed two algorithms: Group A patients having midline attachment and Group B having paramedian attachment in coronal sections of MRI, as you see in this scan. In this scan, you can see here, this tumor is attached to the left side, more on the left side. And so this group of patients were operated to the right side, opposite side. Whereas a midline attachment, we operated to the side of whichever the visual loss is higher. Many cases, we did a DTI to identify the orientation of the optic nerve and chiasm to the tumor to decide the side of approach. So we had 18 patients in group A which had midline attachment, and 42 patients was predominant. 70% of the patients had a paramedian attachment. As you can see here, this is medial to the left optic nerve. And these cases we did to the contralateral approach. So the protocol was group A patients had a ipsilateral approach, which had a midline attachment. Group B patient had contralateral approach. Among this, plano-sphenoidal meningiomas were the most common was tuberculum cellular meningioma in the group B. Plano-sphenoidal meningioma was higher in group A, or the midline attachments were more in the group A, whereas tuberculum cellular meningiomas was more in group B. So if a patient having like a tumor like this with tumor going into the optic canal along the, as you can see here in the scan, instead of operating to this side, we did surgery from the right side instead of left side. And we did assess the visual recovery using the German visual outcome using German score, both pre and post operatively, taking into account the acuity and the field defect, and you get a score in this chart. Statistical analysis was done using SPSS statistics. All the 60 cases were collected and analyzed over 6 years period. We do a small frontotemporal orbital craniotomy, or sometimes only TDNL craniotomy in order to approach these cases. The first step is to release CSF from the interoptic and keratotic optic system. You can see here the normal optic nerve, then identify the tumor, devascularize the tumor, and follow the normal optic nerve, because many times the opposite optic nerve is stretched out, it's difficult to find out. Follow the normal optic nerve, follow the chiasm into the abnormal optic nerve. So that one dissects the tumor after decompression and devascularization. One can dissect the abnormal optic nerve without touching it, like dissect the tumor from the nerve rather than nerve from the tumor. As you can see here, the tumor in the video, if it's seen well, that the tumor is being decompressed and removed. And in this case, at the end of tumor decompression, what we noticed was there was an aneurysm in the paracranial ICA. And this, because it was done transcranial, this could be clipped. This aneurysm could be dissected and clipped. Out of 60 cases, we had 3 patients when we found aneurysms in the paraclonate, which intraoperatively, which are not detected pre-op, but we had clipped. And when we analyze them post-operatively, gross total resection was done in 97% in the contralateral and 94% in the ipsilateral, not significantly different. But what was significant different was with the recovery of vision. In ipsilateral approach, vision recovery was there only in 50% people, whereas in a contralateral, visual recovery was 88%, which was significant. The recurrence rate, as the attachment was practiced better in the contralateral approach, with the follow-up of 3 years, the recurrence rate was 5% in ipsilateral and 0% in contralateral. And when we compared our own results with our previous publication, the visual worsening had significantly come down from 7% to 0%. So this is in our own study that the visual worsening has significantly come down and the visual recovery was better. And this was published recently, published in October in World Neurosurgery, that deciding the approach depending on the base of attachment. This is nothing new. Many other people have. There's a publication 2021 where again they approach a contralateral approach. This publication was again 21 for a contralateral approach. And these are three more videos which have been published with the contralateral supraorbital library approach for tuberculum cell meningiomas. And there is another paper in 2021, all of them in the last 2 years. But we have a largest group of 60 cases, they have lesser number of cases. So if you compare with the published contralateral approach, the visual recovery is almost similar or to the literature published by other people who have done contralateral approach. In conclusion, patients with suprasellar meningioma undergoing surgical resection, thus the choice of treatment depends on the attachment rather than the side of visual loss. If the attachment is paramedian, it is better to operate from the opposite side to the side of attachment to have a better visual recovery as you remove the tumor without manipulating the optic nerve. Thank you for your attention.
Okay, Sam.
Thank you, dear Professor, for this excellent presentation. Is there any question?
Professor Goel is there, he'll definitely ask.
Yeah, Manas, I heard your presentation. That was very good presentation. You see, I like to do ipsilateral frontal, subbasal subfrontal approach. Yes. My argument is that, you know, the more compressed optic nerve and the already affected optic nerve, you know, you can handle more safely. On the other hand, I don't like in a largish tumor, dealing with normal optic nerve may be a little bit tricky because, you know, the function is normal and you can unnecessarily dissect in that area. So that is my argument, that go in the affected vision site, identify the optic nerve, decompress the tumor, release the ipsilateral optic nerve completely, and then dissect in the region of the unaffected or normal optic nerve. So that is my feeling. The only thing that I saw in your presentation was that you didn't refer to my article, which is the largest number of cases of tuberculum celli and the most cited article in the history of tuberculum celli meningioma, which you have not cited in your multiple articles. So that makes me a little bit not so happy about the whole story, Manas, to tell you the truth.
I'll include that. So I thought I'd done that in the literature review.
Don't worry. This is you know, every article of mine is like my baby. You love your baby, you love your articles, and that makes you a little bit, you know, whenever I see that article, I see only pointedly what you have referred or not referred. You understand what I'm saying, Manu?
Yes, sir. Sorry,
you will see in the future, somebody works on contralateral approach and they don't refer to your article, you will be certainly not too happy about it. You understand what I'm saying? But don't worry, on the whole, I like smallish little ideas should be encouraged. One little idea is more than 1,000 people operating for 1,000 years. So this is an idea. Contralateral approach is a thought process, and it is you have worked over it, and my feeling is work more on it and develop a more comprehensive strategy on contralateral approach. And I wish you all the best, my dear Manas.
I'd like to jump in for a second. This is not usually what I do, Dr. Goel. First of all, welcome to the King. I call him the King out of respect. He goes all over the world. He always is ready to televise. But we had a webcast last night with Paul Gardner, and he cited you a lot. And I was thinking that, well, maybe we should get Atul and Gardner to do a few series together. But we'll talk about that later.
Okay,
Onward with your presentation, Manas.
okay, John, thank you very much, my
Comment,
dear
please.
John.
Can I
Manas,
have a comment, please?
Yes.
Yes, thank you. Good morning from Turkey. I'm Dr. Najjar from Syria, working in the border of Syria and Turkey. Thank you for your presentation and for the comment from Professor Goel. Actually, the problem of the vision defect post-operative is not concerning on the side of the approach, because when you choose a normal vision side to do your approach, your optic nerve will be at risk, because it's depends on the involvement of the tumor intact canal. First point, and the second point, it's regarding to the feeding branches of the let's say the sub-optic feeding very fine arteries, which is very difficult to preserve, and still your intact vision will be at risk. So I think the most neurosurgeon choose to take the approach from the affected side, because anyway you use your technique, your intact side will be at a high risk if you choose for your approach. Thank you.
Yeah, means here the attachment is medial to the optic nerve. So, and if you believe that endoscopy has a better visual loss, which also they have means published in literature, because they first attack the attachment and devascularize the tumor, and without manipulating the nerve. So this follows the principle of using the endoscopy, advantage of endoscopy in transcranial surgery.
Manas, I have a question.
Yes.
You had 3 aneurysms detected during surgery, or did you able to diagnose preoperatively?
No, all are during surgery. None of them were preoperatively diagnosed. So it was not seen in the pre-op. Means we don't do an angiogram for all these cases, but the routine plain and contrast T1, T2 did not suggest that there was an aneurysm. And there
Yeah,
was
I
no
had recently operated to suprasellar meningioma, tuberculum, and there were multiple aneurysms actually, but not seen on the preoperative MRI, or we don't do routinely angiography. And on the left side, clinoid aneurysm, I was just cutting the last attachment. I saw, I mean, it was a difference of putting a nick in the aneurysm actually. So it was a real horrifying situation when you come across aneurysms, which you don't know whether aneurysm will be there in tumor patient.
That is one problem if you do a transnasal endoscopy surgery, and then if you have an aneurysm bleed, then it will be fatal for the.
On the other hand, Manas, I have to say
Yes.
that it's a very unusual finding, and you must report this observation of yours. I read one article by Vinko Dolans several years ago. He had done one suprasellar meningioma where he identified an aneurysm during surgery. I think other than that,
Yes.
I have never seen any report. 3 cases that you have seen, you must collect and make a very nice publication about it, Manas.
I have one case, sir, recently operated, and both the carotids, there were aneurysms actually, which we did angiography after surgery. And but during surgery, we could find aneurysm on the left side, just below the clinoid, and we just wrapped it. I couldn't clip that.
These aneurysms are usually wide neck aneurysms,
Yes, sir.
tumor related, and rupture
Yes.
can be fatal. You see, if they rupture, the whole story can be difficult to control during that time.
Absolutely.
And sometimes we prefer very minimalistic approaches. We do small supraorbital and eyebrow approaches. And if the artery ruptures, you know, the handling of instruments also is not such great. So that is the reason sometimes I wonder if a little bit largish approach is necessary, or more particularly in dramatic cases like this one. So that is the thing. Usually everyone now prefers a very smallish little mini approaches and all those kind of things. But in this situation where dramatic arterial injury can occur and where you need to anastomose, sometimes it ruptures and you need to take 1 or 2 sutures. And in those where you have to take sutures, your instrument handling may not be all that good in a smallish little approach. So a little bit largish approach, not very minimal, largish approach is better for tuberculum celli meningiomas. This is my feeling.
Thank you, Professor Manas and Professor Goel for this excellent presentation and discussion. And now we will shift to next speaker, Professor Rangish. Please start sharing your screen.